At the same time, he is also doing work in India. So, friends, we have Dr. Madhav Suri as a guest lecturer today, and our chairperson for the meeting is Dr. Praveen Kumar, who's with us as a senior consultant in pediatric neurology and a very, very hardworking person who is always available for all academic research as well as patient care. So, Praveen, over to you to introduce Dr. Nandan and Dr. Madhav Suri.
Thanks, sir. Thanks very much, sir. A very good evening to all of you. I think we are privileged to have both of our very senior pediatric neurologists amongst us today, and both of them need no introduction about the part. A couple of months back, also we had a very interesting series of EEG workshop, which was held in Gangaram by Dr. Madhu Sari sir. It was very much appreciated by one and all about the part. Very useful, sir. And Dr. Nandan Adi sir is practicing in Pune, and he has got his own very good setup with the state of the art EEG facilities. But I know about the part. And today we are here to discuss about a very pertinent topic about the EEG. A lot of us, as a practitioners, we get to see the EEGs, we get to see the EEG report on the part, but how much it is really correlating with the clinical findings, how much really correlating with the aim which we have sent the EEG, is it really correlating, or is it making some sense or not? I think that will be dealt by Dr. Madhusari sir today. And over to you, Dr. Nandanadi sir.
So I think, thank you very much for the kind introduction. We have amongst us a stalwart in the field, Dr. Madhav Suri, who has kindly agreed to speak on a very, very important topic, because most of us pediatricians, when we get reports of EEG or we send the patient out for getting an EEG report, we need to know what is written there, and we need to know at least a few basics, which he's going to tell us about, and how to look at these EEGs, what is a normal EEG, what are the variants in the EEG as per the development age of the child, and so on. And then the pathological things that actually change the EEG, the pathologies, different pathologies that go on in the brain that change the EEG. So it's a very, very important and a very basic topic that all pediatricians should know. And Dr. Madhav Suri has already been introduced. So I think I'll hand it over to him to begin his talk without wasting too much time here.
Let me just intervene for a second here, and that is that today in the OSCE, in National Board of Examinations, we do get EEGs to interpret. So it is very important for the DNB students also to learn how to interpret the EEGs, at least the typical ones, and difference between normal and abnormal, and so on and so forth. So it's not just ECG, but also EEG, which is required for your training. Thank you.
Thanks.
Thank you all. My name is Madhav Suri. I am right now in California, but I'm actually in Delhi. My heart and mind is in Delhi. Only the body moves here. I have a mission for which we are working with the Gangaram Hospital and the ICH team. I thank Dr. Anupam for setting this up and make this possible. The mission is to train EEG technologists to US standards and to train them and make them certified to US boards, which is American Board of Registered EEG Technology. Therefore, they will be registered EEG techs. You may not know, but most EEGs done today are not by registered EEG techs. They are simply people who have learned mostly on the job, and they have had a theoretical training for 1 or 2 years. We're trying to formalize that training. Secondly, we have a channel open for pediatricians and internal medicine, neurologists, whoever's interested in certifying for EEG to take the American Board of Clinical Neurophysiology and get certified in India, giving the exam over there. Now, having said that, I'm going to talk about something that I hope will be of clinical use to you. Very little will be about the actual interpretation of EEGs, which is a different topic by itself, but I'll be showing you a lot of EEGs. So my background is an MBBS in Maulana Azad, Pediatrics, MD with Dr. Walia in PGI Chandigarh, Pediatrics in New York Medical College, Adult Neurology, Child Neurology, and a EEG Epilepsy and Clinical Neurophysiology Fellowship with Dr. Moshe, Dr. Goldenson, and the team at Einstein. And then back to Gangaram in 1989 to start the Epilepsy and Pediatric Neurology department there, which is now flourishing. And Dr. Praveen is leading the charge there. So again, thank you both Dr. Praveen and Dr. Nandan for bringing pediatric neurology to where you brought it in India. This is very much needed. It's a big area of that needs further development. I love working with you and appreciate you giving this opportunity for me to talk. It's about dinner time for you, and before that postprandial feeling comes over, let me tell you where I am. This is what I see outside my office on Cedar Avenue. A few months ago, the snow has almost melted because now the temperature is about 110. Yesterday it was 110. You go down the street, this is what you see at the end. And another 20 miles up north, and you have Yosemite. So you're all invited to come and hike in Yosemite when you get a chance. All right, we'll come to the first point. When you're looking at an EEG report, it's important to know how that was derived. So some key elements. One is you should have an idea of how we record EEG. This is the montage, that is you're recording electrical potential at different points. FP stands for frontopolar, F is frontal, C is central, P parietal, O occipital. Go through this real quickly because for some of you, this is already well known. But just to be sure that we are on the same page, this connection, FP1 to F3, all the way down to O1 is called a chain. So this becomes a left-sided chain, which is sitting on top of the head. Then there is a similar right-sided chain with even numbers. So odd is left, even is right. And this is the high-lying chain. Then there's a low-lying chain that is from frontal to occipital. And there is a similar low-lying chain on the right side. So left side, low-lying chain, right side, low-lying chain. These four chains cover the whole head. We will use this montage for most of the recording. Now, the other things that should be mentioned in your report should be that they recorded using a 1020 system. Some reports don't mention it. It should talk about the filter settings. It should talk about the technical conditions of recording. I'll come to that a little further down, but in this recording, what you're seeing is an obvious abnormality, which I will circle. When you get a report that only talks about the obvious abnormality, they are probably missing other things. What are these other things? So these other things can be this area, for example, you see, this is not a typical spike, and this is actually an artifact. So first thing they should mention in the report is if they have identified any artifacts. Almost every record will have some artifacts, and that should be commented on. Then you come to the obvious abnormality. Here's another artifact to be aware of. You see this repetitive, almost occurring at 5 to 6 times a second. It's continuous all the way through. It doesn't have an aftercoming. There's no slow wave after this spike. This is nothing but the left masseter muscle, which is firing. This left masseter, and this is an EMG artifact. One of the things as fellows we used to talk about is this joke about magnetic tape recordings which are done on Memorex. And there was an ad that Ella Fitzgerald, a famous black singer, could sing so well and be recorded on Memorex that if you played back Memorex tape, you could shatter a wine glass. So your question, is this live or is it Memorex? Basically, we're questioning whether the finding is an artifact or not. This here in the corner, that's the artifact, okay? This here is the abnormality. Now, the other thing that we look for is, you see inside the rectangle, where there isn't too much activity, but actually you will see in the back, this is occipital P4 to O2. In the occipital chain, there is a rhythm. This is the alpha rhythm. And it designates the posterior part of the head, the back part of the head. And it should almost always be a comment about the posterior rhythm. Almost all records I've seen will talk about it. And if you don't see that, then there's a glaring abnormality in the report. So we look at this posterior rhythm and we look at this here in front of it, what we call the general background and the general rhythms. And I won't get into too much about how you separate it out, but you need training and visualization of many records. And it is possible once you start doing it, it's like cycling, you know, it's second nature to you. You know exactly what you're looking at. You don't have to think about it. It becomes almost autonomic to figure out what the background is. A background is important in some situations, and there should be a section in the report. I'll come to the report and mention it, but one area where background is very important is hips arrhythmia. Okay, we'll come back to this in a minute. Just hold that thought for a moment. So we did the general background, we did the posterior background. Here's another way to think about the background. So I use it as the method you lay out your dining table when guests are coming. So my mother taught me, you put the knife on the right side, fork left, and the spoon is in the front. Glass is always on the right front because most people are right-handed. This layout is called the background. In children, you have a faster frequency in the front and a slower frequency in the back. This is called a gradient, slow, fast to slow. So it's a fronto-occipital gradient. We talk about it in children, and if you don't see it, then something bad is happening. This is help from my helper, Arya, my granddaughter, who provided me her stick-on cup, a fork and a spoon, no knife here, sippy cup and a glass. This is how she lays it out. Children's background is different from adult background. Children, as we all know, are not miniature adults. So they have greater slow wave activity back of the head. They have what we call normal posterior slowing. That should not be called as abnormal. And a lot of time what we see in adults trained neurologists or people reading EEG reports for adult trained, this slowing is called as abnormal. Be careful of that. Also, children tend to sleep with very high voltage activity in the center of the head, the vertex. We'll come to that. They tend to call those vertex waves as spikes. So be aware of that also. The other thing in the report that they should comment on is they must compare the left to the right and look for an asymmetry. So this comparison of the two sides helps you decide which is the bad brain, which is the good brain. Because sometimes both brains can be bad. One can be worse than the other. Okay. We recently had such a case of Dr. Saurabh Chopra's, and we're reporting it, and one side had so much encephalomalacia, it just wasn't firing, and the activity was very low. Okay, after they have looked at this background, they've commented on the asymmetries, ruled out the artifact, then you start describing the abnormality. In most reports, all we get is there's a spike, there's a slow wave. and it is here, it will be surface negative over the left temporal region, surface negative at F7. The report should not just focus on that. There should be the rest of the information we talked about. Okay, this same field, this is more for those who are learning, should be identified in different montages to make sure it is a true waveform and it's not something that is coming as an artifact from outside the brain. Okay, and also we look at the field. I won't get into that too much, but basically it is saying that the activity is maximal at F7, then it gets a little less at the next electrode, and so on. So the activity must show something like this, like a mountain. You have a peak, and then you have a slow fall off on both sides. Okay, that's called a field. All right, to summarize, when you're reading the report, that the person writing the report should comment on the following. And here's a summary. The montage should be mentioned, sensitivity mentioned, paper speed, artifacts, whether they've been identified. Is it organized? And you think of it mostly like a chess set, you know, are the jo प्याजे हैं वो आगे हैं और queen है वो पीछे है. That organization, that's called organization. वो है कि नहीं? Then the general background, posterior background, is it asymmetric? Sometimes your asymmetry can be explained, if you have a good technology especially, by simply the head position. They should write if the head is to one side or the other. Head leaning on one side causes more pressure on the electrodes on one side, changes impedance, and activity can look higher or low voltage. If you got IV extravasation in neonate, you got a scalp swelling, it's going to decrease the amount of signal passing through that chunk of fluid, dextrose saline that is sitting in the scalp, and you'll get a lower voltage on that side. That is not an abnormality, it's an extracerebral abnormality. Similarly, if there's a subdural, that's also outside the brain, it's going to attenuate the signal. That is not a cortical abnormality. So those kind of things should be looked for. Then you go for the glaring abnormality. Is there a temporal spike? Is it generalized spike and wave? But natural tendency for all of us is to, you know, in the wedding is to look at the bride and the groom. You don't look at what else is happening. Look at what else is happening. That is the point of this report. And then for the person who is writing the report, ideally they should describe the field and check it in different montages. Okay, so when the description, if there is a spike, they should describe it is 200 microvolts, surface negative. Initially, there's an upgoing wave, then there is a downgoing positivity, then an aftercoming wave, and that wave is negative. By the way, everything that's looking up is called negative in EEG. Everything that goes down is called positive. But you don't have to worry about that too much. That's for interpretation. But if there is an abnormality, it should be well described. That's the point. The idea is that if you come back after a year and repeat the EEG without having the pictures and the tracing, in your mind's eye, you're able to recreate that spike and wave. That is a good report, when you can recreate the image. Okay. Now, here is a template we use in Defense Colony, South Delhi, and we use this in my office in California. If anyone would like it and is wanting to read EEGs, you're welcome to have it. Basically, I've put together the technical summary. The demographics is obvious, right? We put the technical summary here for ambulatory EEG, which we'll talk about, and for routine EEG below that. You simply delete the section that doesn't apply. Then you talk about the organization. We mentioned that this the gradient, it should look like there's faster frequency in the front, slower in the back of the brain. The layout on a dining table, that's called organization.
Sorry,
You have-
Madhav, sorry to interrupt you. Can you speak a little louder or nearer the mic? Because people have sent this thing that you need to speak a little louder.
How is the sound now? Is it better? Is the sound any
Slightly
better?
better, sir. Slightly
Okay,
better, yeah.
I just turned up the volume.
Okay.
So I apologize for that. Let me continue. If you want me to repeat anything,
No,
let
no,
me
it's
know.
all right to continue.
Okay. Okay. So I'm talking about the EEG template that we use. It's a simple word template. It's available to you if you like. I'm happy to share it. But this is how I think a report should be written. It should have demographics, technical summary, and then in the recording description, organization, which we talked about is what's in the front of the brain, what's in the back of the brain. Then you should comment on the different states, wakefulness, drowsiness, and sleep. Then you talk about activation procedures, like you hyperventilated the child, what happened at that time. Okay, then photic stimulation. These are things we do in all cases. We don't do these obviously under 3 years of age because of cooperation. Also, photic stimulation is less relevant as the child is younger because you typically don't get the genetic generalized epilepsy or idiopathic generalized epilepsy in the younger children. Then a line about the heart rate is very important because the heart rate, yes.
Sir, please put your slides on slideshow, sir.
Okay.
Yes, that's better.
Is it coming now?
Yeah, yeah.
Okay. Okay, sorry about missing out that. I will continue from the different parts of the report. So we were at activation procedures and we talked about including hyperventilation, photic stimulation. Under age 3, photic stimulation is not that relevant because you don't get the genetic generalized epilepsy and hyperventilation is technically difficult. So we go to the EKG comment because EKG is important, especially in certain seizures that you're recording. The seizure will affect the heart rate, and similarly, the heart rate may affect the EEG activity. Push button detections is a segment I put in here because when we do long recordings, which I'll show you in a moment, that is an ambulatory recording for 48 to 72 hours, we tell the patient to press a button, which is there on the recorder, if they have their typical event. Typical event would be like staring, a jerk, or if they feel dizzy, confused, etc. So that's also mentioned in the event log. They'll keep a log about these episodes. Then the interictal abnormalities, that is the abnormality that I just showed you in the left temporal region, that should be described in this section. So the importance of separating these is that later on, when you want to compare records, you can go straight to the section where you describe certain abnormalities and don't have to go through a giant mass of words. Okay, we started doing this when I was at Einstein for a research project called a single seizure study with slow motion now. And then I changed it and modified it, and now I find this is very useful in creating a database for EEGs, in doing research, and also in comparing EEGs one against the other. The next part of it is, for me, the most critical, is the classification. So I'll show that to you in one of the slides. It's basically a summary statements. And Dr. Spiro, with whom I worked, my boss in pediatric neurology, said, if you can't tell me a case in 30 seconds, then you really don't know, go back and re-examine. So you got to summarize everything real quickly because everybody's busy. In your head, you got to take the fluff out and just boil it down to the meat. That is the classification. In the impression, you explain, the person who's writing it explains what that classification means to a person who has never seen EEG interpretation before, and he describes the meaning of it. Here you can say this is a normal EEG during wakefulness, drowsiness, and sleep, and there is a epileptogenic region in the left temporal area, or there are seizures arising from the left temporal area that last for 10 seconds, etc., etc. This is the part almost everyone reads, and they tend to just skip the rest. But I've just shown you the importance of the rest. Now, here is a simplified version of how the EEG should be summarized. There are journals written on this, there are books on it, and you will find everyone has strong opinions on it. It's like politics, you're either red or blue. But I believe that we should lump things together rather than split them. And in the EEG, there's been a lot of splitting, so I'm going to lump it for you. The most important is this. This is the paroxysmal activity. This whole thing of dividing into paroxysmal activity, slowing, and paroxysmal activity, but that doesn't have epileptiform significance, was developed over years by the fellows who trained at Montefiore with Doctors Goldenson, Moshe, and I have modified it from there. Okay. You will see different words used nowadays in the ACNS guidelines. I won't go into that, but basically, look, they should be describing in the classification spikes. They should be describing spike and wave. These are the two most common findings you will see. Slowing also helps you decide which side of the brain is worse. These are the epileptiform findings that can occur, but they don't have a epileptiform meaning in that you don't start anticonvulsants. These are considered as benign findings. They're called benign variants or non-epileptiform variants. So if you see the person describing this, that person who's writing that report is well trained. Sorry? So that is an indicator that the report has been done well. Okay, here is an example how you should not record EEG. So we got this patient from UP, and you see this rhythmic activity. It continues. There were 50 pages. It is the same right through. Okay, there's no change. They do show a montage. They do show over here that the montage has been applied like it should be. There's absolutely no change in this recording all the way through. In the report, they say it's alpha activity. They say spike in sharp and slow waves, discharges at places, no description of what the spike is or the sharp and slow wave is, where it is happening, and the impression is interictal epileptiform discharges at places suggestive of seizure. I think this does not fit what we have just gone over. First of all, if you measure the activity, this rhythm, which is monomorphic, is about 18 hertz. By definition, alpha is 8 to 12. So anything over 12 would not classify as alpha. So this is either a machine-generated rhythm, it's non-biologic, we're not sure what it is. Alpha should show changes. So eyes closed, it attenuates, eyes closed and it appears, eyes open and it attenuates. They don't comment on that. But this is the way you would question findings that are written in certain reports. This patient went on to have further workup done, and I will show you her ambulatory EEG. The next important finding, in addition to focal findings, will be this, where you can have a spike and slow waves, a spike and slow wave, spike and slow wave, a soldier, then a dome, a soldier, then a dome, soldier, then a dome. We call that regular. See, it's a 1-to-1 correlation between this guy and this guy. This you may see in your DNB boards, as Anupam pointed out, because it's a very common finding in the school-going age group. You have a child who's staring and is diagnosed with daydreaming or with attention deficit disorder, actually on EEG, has these findings and has classical perimol seizures or classical absence seizures. Okay, so remember this three, the number 3 and the R regular. I'm going to come to that. This spike has a slow wave that follows. The spike has a slow wave. This one-to-one correlation is the hallmark of this finding. Look at this recording that we did. This person has many spikes and then a slow wave. Those many spikes are called polyspikes. Another example, multiple spikes and then a slow wave. It's generalized, means it's in both sides of the brain. This poly component to the spike indicates intractability. Therefore, your reader should comment on these things and guide you that, hey, it's polyspike and wave, and mention in the impression that it's going to be harder to control. Look at this example, out of polyspike and wave. This patient we recorded 2 years ago is now 35 years, came at 15 years of age, has stayed on 5,000 milligrams of Keppra, not to reduce it. It's one of my highest doses of Keppra. Keppra is levetiracetam. Sorry to using the brand name, but a high dose of levetiracetam to control the seizures also is on lamotrigine. So you can see how the EEG helps you in prognosticating. This is the slide I want you to put in your memory bank, in your temporal lobe, will help you all the way through. This is my simplified assessment of spike and wave. If the frequency is 3 Hertz, the magic number 3, it's going to be easy to control. It's likely to be genetic epilepsy, and it will likely remit. So you can offer a good prognosis, possibly to the patient. If it is faster than 3, 4 to 5 Hertz, then you're more likely to see things like myoclonus and generalized seizures. Generalized seizures are less common in absence. Usually staring occurs, absence occurs. But here, when it's faster, 4 to 5 Hertz, you'll get myoclonus and generalized seizures. That is juvenile myoclonic epilepsy. Variation of that is you can have absence plus generalized tonic-clonic, and that is juvenile absence epilepsy. Now, take that number 3, slow it down to 2.5 Hertz. If the frequency is slower and it's 2.5 Hertz, this whole entity is called Lennox-Gastaut syndrome, where you have slow spike and wave. The word slow implies it's slower than 3 Hertz. Here, fast implies it's faster than 3 Hertz. So you see where these words came from and what they mean. And that's what, when they are in the report, it tells you how to get clinical information out of that finding that the report talks about. In this type of seizure, these are the ones that Dr. Nandan and Praveen will have. You will send them to them very quickly because they're difficult to control. They have multiple seizure types. You have absence, you have myoclonus, you have generalized tonic-clonic in that group. They also evolved from bad brain. And again, in the other EEG example, I showed you polyspikes and then a wave. That polyspike and wave indicates intractability. Okay, so this is a little deeper dive into the technical aspects of EEG, and I'm going to get into my favorite area, which is a very pet area for me, which is the misdiagnosis from EEG. If you get a chance, go down to your lab, take a look. If they're using monitors with high resolution, like 1920, that indicates to you that they're aware that the image should not be pixelated, the spike should be sharp, and they are taking care of that. If you look at the recording and you see a 35 Hertz filter being used, the recording ideally should not use this unless you're in the ICU and everything else has failed. In the ICU, you have a lot of electrical artifact. You have pumps and ventilators and so on going on. So you will pick up that electrical noise while recording. And it's common that the technologists will use a notch filter. This is the line frequency, that is In Delhi, India, line frequency will be 50 hertz. Here in California, 60 hertz. So the notch will change from 50 to 60 hertz. And can be used, but we prefer that you don't use it. Then the sampling rate, we'll talk about it later on. This is very important in choosing your amplifiers. Then if they are always displaying their EEGs in color, red and blue, for me, that is something to avoid, because in your mind, it biases you to one hemisphere or the other, depending on which color preference your brain is wired. Everyone's got a favorite color. So color tends to bias you. I prefer black and white for that reason. Also, the montage should be simple. Use that KISS principle, keep it simple, stupid, and that you use linear montages, longitudinal. You don't use the montages that cross over. Some people like to use those. That's complicating your life. Okay, then look at the duration that they record. Most of the hospitals you will see record 20 minutes. Okay, here in the US, they record 20 minutes because that is the minimum that insurance requires to bill. But we record typically 1 hour in Defense Colony in Delhi. We record 1 hour here at my office, because we are trying to capture the change from wakefulness to drowsiness to sleep. In 20 minutes, very hard for you to fall to deep sleep and get at least some element of stage 2 sleep. Okay, so the duration will help you in making some judgment about the quality of your record. Again, if there is a lot of comments about central spikes, spikes coming from the top of the head, beware, because there's no cortex in the top of the head. There's nothing but a giant, yes. So there is a giant channel called the superior sagittal sinus. And the sagittal sinus is not a generator of EEG. Most of the generators are going to come from the temporal, then the frontal, and then the occipital area. So we tell the persons who are starting new in EEG, focus your effort first on the temporal area, then look at the frontal area, then look at the occipital area. And avoid over-reading. We'll talk about overreading in just one moment. This has been well described in the UK, Denmark, and India. It's something I wanted to get into, but we have not written it. But I'll show you our experience. And I've talked about the keeping it simple principle and using lumping rather than splitting. Okay, in terms of EEG reports, over 30 years, since 1989, observing EEGs that were done in Sir Gangaram Hospital and in a clinic that we ran in South Delhi in House Khas with Dr. Sabrawal. And also seeing it in California, it happens here as well. It's very common to see misdiagnosis in the EEG. And once there's misdiagnosis in EEG, it leads to anticonvulsant therapy, and you know what the consequences are. The most common reason is inadequate training, because most of the interpreters are trying to use a pattern recognition approach. That means you look at the EEG, you look at the textbook, you try to match one pattern to the other and say, this looks like this, therefore it's this. Instead, the way we teach it to our technologists and to the persons who do EEG with us in the Surrey Neurology Center is localizing the activity, localizing by looking at the field. And that's the mainstay of our methodology. Also, the difference between adults and pediatrics in reading EEG is huge. The problem occurs even here. Many of the adult people reading EEG, the minute they look at the EEG and say, if it's under 10 years of age, you give it to the pediatric neurologist or give it to someone trained in reading EEGs for children. If it's neonatal, for sure, give it to them. They will not like to read it. because so much changes in childhood. You know, you have the preemie and it's going to go through changes in background. The EEG of the infant is different from the neonate. As the infant reaches 1 year of age, gets a posterior rhythm, that is different from an older child. So you need to be familiar with the maturation patterns. And that in itself is a whole training session. Then there is a natural tendency when you get a EEG, say, let's say for syncope of a passing out episode, that you're going to confirm the diagnosis. So it's called a confirmation bias, and you tend to find something which isn't there, and you're looking for that abnormality, and therefore you describe it. So every little waveform starts to look like a spike. You have to be careful in those situations here. And we talked about technically limited studies. Just showed you an example from UP. So be aware that if you do not have adequate cerebral waveform being recorded, we use a term amongst ourselves that it is a non-EEG. The definition of a non-EEG is when you record something and it's got no cerebral activity, but it's got something else in it. So I don't mean to be facetious, but some technical recordings we have seen are simply not anything to do with cerebral activity. Okay, the next point is about those benign EEG patterns that Nandan was referring to. These are the normal, or these are spikes that can occur in normal individuals, but they don't have a meaning that that person is going to have increased tendency towards seizure. And these consist of small sharp spikes, pulse, and so on. If somebody describes them but does not call it in the impression, then you know that you are dealing with somebody who's well trained. So that's another clue that you should look for. And the last point is, see, when with the digital EEGs coming in, prior to that, we've been recording on GRAS machines on paper for years at Huskas. We would give the GRAS machine record to the patient. They could take it to any doctor and show it to them. The whole record traveled with the patient, right? Now with the digital EEGs, because of proprietary software, unless they use a EDF format, which is European digital format, you cannot read Cadwell EEG on Nihon Koden and vice versa. So there is that problem of looking at some EEG done somewhere else. Okay. On this line, I will mention one area on which we have written a paper with Dr. Sabharwal, but we have not published it, that the rate of misdiagnosis, we just looked at the rate of misdiagnosis, 1 in 4 cases in the UK was felt to be misdiagnosed. We couldn't find this as any journal article. This was around 2005 when I started looking at it. I found it on a BBC website. And apparently this was a number that was derived because a single pediatric practice was audited and they found that the person running the practice was making diagnosis of epilepsy by doing EEGs which were normal but called abnormal. And they estimated from there that about $257 million in misdiagnosis had been spent in the UK alone in 1 year. If you extrapolate for India, where the person with epilepsy, we estimate a 5 million, we got at least 1 million that are incorrectly diagnosed. So you have to be aware of this and you have to be sort of look at the enormity of the problem, and that's why go with a center or go with a method that is reliable and well tried. Okay, I'll show you that the problem is not just in New Delhi and North India, from where we've been reading EEGs. Look at this slide. This is from the American Academy of Neurology website. I did this survey in the pre-COVID time, 2019. they're asking, how often do you read EEGs? How are you trained in EEG with a fellowship? And how many you read per month? Okay, these are my answers, the light green. If you look at this, you just add these two numbers up. Okay, 20% would be reading EEGs weekly, but the rest, 70%, don't read them regularly or read them on a monthly basis. Okay, that is US board certified neurologists that they are serving or US trained neurologists that they are looking at. Then you look at, have you had specialized training? The answer is no for more than 60%, and another 20% have had epilepsy training, but not necessarily EEG training. There are two separate types of fellowships that run. Some fellowships just focus on treating epilepsy and doing the epilepsy surgery part. The EEG portion is not that dominant. So EEG interpretation in those fellowships is not that prominent. That's why they separated it into two sections here. So if you took this out too, you just have 80% without training, or 80% I would say with training during their fellowship, their residency alone. Now, what is a residency training? I asked somebody in one of the big centers here in the US, as well as in New Delhi at one of the premier institutions. It is 3 months of training in their 3 years of residency. Those 3 months can be separated, means they could do EEG 1 month and then they could switch to EMG, then they could do clinics, then they come back to EEG. En bloc, 3 months is given in some fellowship, but not always. Now remember, the resident, it takes him 1 month to figure out where the bathroom is, where the montages are. Then he gets familiar with the EEG, and then he starts to get trained. By that time, he's switched to the clinics. Okay, and last point is that look at the number of EEGs being read by US trained neurologists. If you add these two numbers up, you've got 80% who are reading 20 EEGs or less per month. That's less than 1 EEG a day. It's way below what you need to maintain your skills. So I think I made my point here. And that is what the Coke girl said. You drink more Coke and you read more EEG, you'll get better. Okay. We'll skip this one, which is the rules for identifying ictal discharges, because we are just getting into ICU EEG monitoring, and we hope to do it at several hospitals, starting with Gangaram Hospital, and Dr. Praveen and Anupam are going to direct us on that. But I want to give you a little feel for what can be recorded, okay? So a lot of times you could do EEGs, they are normal, the report is normal, but the patient's having seizures, you don't know what to do next. Here is an example of a 23-year-old who came to us, and this is almost 20 years ago. Look at the date, it's in the bottom right-hand corner, okay? He had 6 seizures, all at nighttime, random, separated in time, 3 months, 4 months apart. He went to different parts of the Central Valley. Where we live, it's kind of like Punjab, small towns separating by one big town in the middle. So he would go to different hospitals. In these hospitals, he would have EEGs done. They were all normal. So then he came to us and we did an ambulatory. Okay? Ambulatories, I'll show you the setup in just a moment, but it's a continuous recording where you're recording the EEG, at least 16 channels EKG, and this right here is what's going on. This is a montage. Patient is at 1:17 in the morning. The background is while asleep. And out of this background, suddenly you see this sharp sawtooth-like activity starts suddenly and starts to build up and becomes very rhythmic around here. It's greater on the left side as compared to the right side, okay? And then it continues. Each of these green markers, by the way, is 1 second. I'm sorry, I forgot to tell you that from here to here, this whole epoch is 10 seconds. So this lasts for roughly 12 seconds, and it starts suddenly and abruptly stops. Here he wakes up, there is an eye blink, this is an eye movement, this is an eye movement. And as we said earlier, when the eyes open, this is and they close, the alpha appears, and you see good alpha that follows right after that. He is alert. There's some muscle activity right here. Okay, you can actually record the seizure very well by doing a long recording. Once again, you have a background in sleep. See how symmetric it is. It's artifact-free in these ambulatory recordings. You have a clear onset, which is coming on the left side, which is greater than on the right side. Activity is also greater on the same side. It has a build-up, meaning it becomes more rhythmic and more synchronous, and it abruptly ends, which are the criteria needed for a seizure. And there's the eye opening and eye closure. This negativity upwards is the eye opening, and when the eye closes, then you get this downward deflection, and you get alpha right after that. Okay, in this case, MRI was negative. Only the EEG gave us the answer. We finally did a PET study on him. It showed hypometabolism in the left temporal lobe. And he got controlled on Keppra and lamotrigine. Okay. Again, we are switching now to show you that these abnormalities from the textbook by Dr. Goldenson from the 70s. These recordings are on paper. See how beautiful they are with polyspikes and then a slow wave, polyspikes and a slow wave. And I showed you this, what we recorded in that patient we followed from 15 years to 35 years of age with generalized and myoclonic seizures. Polyspike and slow wave. Poly indicates intractability. This polyspike and wave. Sometimes you can get single spikes in this situation. From the teaching standpoint, it's just to show that sometimes isolated spikes can occur together with generalized spikes. So we don't necessarily call that as focal epilepsy. It is still a generalized epilepsy. You can only understand these kind of dynamics if you do a long recording. In this case, we got this fragment of the single spikes in the 14th hour. Look at this, 14th hour of the recording when we did an ambulatory. If you do routine recordings, all this flavor is lost. The understanding of the epilepsy is limited. Again, polyspikes in that patient indicating intractability, which is why he's still on 5,000 milligrams of levetiracetam. Okay, we're nearing toward the end of the discussion, but I have a few very important issues that I would like to share with you. Please don't get thrown by this detail on this slide, but this is to show you how the equipment that you use has significance. When we recently upgraded our equipment, by the way, I use Cadwell equipment, but I've used all other types of equipment, including GRASS, Nihon Gordon, Telefactor, Biologic, etc., and aegis. It doesn't mean that I have a financial relationship with Cadwell or I'm speaking for them. I am simply pointing out to you that I am most familiar with this equipment. I've used it for 25 years, and these are my reasons for choosing it. This is this slide right here. Look at this line out here. This is when the software was upgraded, 2021. And in the nearest competitor, Natus, we found that their software was upgraded in 2012. So there's a 10-year difference here in the design of this equipment. And that is a huge amount in software and computers. Look at this line here. You see the second line in gray? This is the sampling rate. The current equipment we use is Apollo, this one. It has a sampling rate of 1 megahertz. This is what we use in California. So that's, I will show you some recordings on that. This is what our techs are now training on, the Apollo system. But The nearest competitor, Natus, we could not get the numbers for them, but I was able to get it from an engineer. The highest sampling rate here is 512. So compare 512 to 1 million. You can see why we prefer this sampling rate over this sampling rate. This block here refers to the easy amplifier. This Cadwell easy system is what we're using in Defense Colony. Sampling rates here, if you go down to this section, is 3200. We have an easy 3 system at 4000. Still, it is way above what is required. The nearest, as you can see, system that is available by Natus is 512. I don't know much about the Chinese machines available. I could get that information, but we'll have to look at the spec sheets. Okay, this is not important for you in terms of the physics of why we do this, but basic point is, look, if we were to take a waveform and we took points all along the waveform, versus if we took a point here, one there, one here, one there, one here, when we recreate the waveform, it's going to look like this. So this will look like this, and that's called undersampling or aliasing, and we want to avoid that. That is the risk of recording something with a poor quality amplifier. Okay, this slide is just to show you that, yes, and
No, Suri, could you please wind up now?
okay, so the classification is what you should look for in the report. I've gone through all those steps. I will show you how we are doing EEG interpretation in order to minimize errors and make the report more accurate. When we do an EEG in South Delhi in Defense Colony, it's first reviewed by a technologist. It is then reviewed by the EEG trained neurologist who works with us, and then it is reviewed by me in a conference where we review all the abnormalities. Now, this method is called the Swiss cheese model of reading EEG. I made this term up because it is basically an idea that came up that if you had a wheel of cheese, you know, when you make cheese, you get a cylinder of cheese. You slice it into 3 sections. You give 1 section to the technologist, 1 section to the neurologist on site who's reading, and 1 section stays with me. Now we rotate that Swiss cheese cylinder by quarter turn, 25%. If you do that, the holes that of an error are less likely to line up, and an error that would occur in this first phase, second phase, or third phase of reading is less likely to occur. So this is our method to improve the quality of reading EEGs. Our technologists are going to be ABRIT certified, and they're giving the exam. We have a total of 6 technologists, I believe, in India who are ABRIT certified. 6 total in all of India. Okay, 3 of them are with me, and we hope to get 2 more certified in this year. So we hope to improve the quality further by having well-trained technologists, because they determine the data that's recorded. This I want to show you is how we have improved the EEG report. We record long EEGs. On the left is California, on the right is New Delhi. This is our first child, 13 years of age, and our first ambulatory recorded in March. It's that same patient I showed you who had that monomorphic recording coming from Lucknow. She had a video also done. She had about 6 EEGs in different places, and she has a focal seizure that arises from the F8 electrode. We recorded about 8 of these in 2 days of recording. She also had a stereo EEG, which is nothing but putting a knitting needle into the head. It has contact points. You record the EEG with this invasive technique. It was done in Delhi at a hospital. They tried to thermocoagulate the lesion, and it made the seizures worse. So we stopped. We're going to try a different way of treating this. possibly with laser. It's called LIT. We can discuss it in the discussion format, but it's not yet available widely. We are using it here in Fresno. This is the recording here in Fresno, the same Cadwell system, it's recorded with an amplifier, batteries on the side. But the difference is they also have this suitcase that goes with them, which has a tablet and a cell phone, and it gives you video together with the EEG. Okay, we're going to bring this to Delhi shortly, but the training is ongoing for this. If you need any help with your EEG reports, you would like to learn further, please go to our website, which is listed down here. At this point, you can take a screenshot of this location and you can contact our facility manager, Kavita. She's very helpful. She'll help you. Okay, we have 4 neurologists there and they will help you too if you have a particular problem with a patient. If you need to reach me, and you're interested in certifying or learning more about EEG, or you have a technologist who wants to become ABRIT certified, here is my contact information. I will stop, and I thank you for your time and for your attention.
Thank you very much, Dr. Madhav, for giving us in a nutshell what is the very brass tacks of EEG, how to look at it, how to record it, how to look for abnormalities, and what not to do, how not to record it. And of course, talking about how good training helps in interpreting and recording and interpreting EEGs. So I think we can go to some questions that have come here. One of the questions is from Dr. Harish Kadiri. Sir, most of the time patient won't be seizing during the time of recording. So we diagnose the pathologies by interictal recordings. So would you like to give some more information to Dr. Kadiri?
Yes. So I'm going to illustrate it with this case, okay? Can you see my slides?
Yes.
Can you see?
Yeah,
Yes?
yeah, we can see.
Okay, 15-year-old with the same problem that you stated came from West Bengal. The seizures were recorded in March. This is about the 2nd or 3rd ambulatory we did. Here is the history. They've been going on for years. We thought the pediatric neurologist, Dr. Chopra, felt that noise may be a trigger. So we tried to mimic that. Various EEGs were done. These were all normal. MRI showed abnormalities. EEGs that were done at these centers were all normal. And I am going to go to the first seizure. Now, remember, this is recorded here. If you look on the top, bottom right, in March, 10:15, about 15 hours into the recording. You see this spike and wave, and there is some muscle activity. The background was very quiet here, and there was a little bit of movement that occurred following this. Each of these is 1 second. So this whole time epoch is 20 seconds. About 12 seconds later, you start seeing spike and wave, spike and wave. You see this? Bilateral. And it goes on for more than 60 seconds and gradually peters out. This was one of his seizures. This is another one of the seizures that occurred. This was in the 19th hour of the recording. Okay? Again, spike and wave occurring, frontocentral. And it continues for nearly 90 seconds out here. Now, had we only done a 1-hour recording, we would have missed all this, right? I'm going rather quickly through this, but this one too, we felt was an electrographic seizure where there was no change. The father could not tell us there was any change in the patient, but there was all of this activity going on in the recording. You see how clean it is, and it is beautiful even 21 hours into the recording. But this activity continues. Now, this patient was having seizures with this frontocentral activity. And look at this. This is this was the second day of the recording. This is 6 hours into it. He has this spike and wave, and then this fast activity. We call it paroxysmal fast activity. It occurs in sleep. There's no movement, or maybe you could say a little movement because there was a change in the EKG channel, but hardly any EMG. And these kind of buzzes are going on in the head. Look at this fast activity. It continues all the way through. All of these are polyspike and wave or generalized beta activity that is paroxysmal, which is fast and meets the definition of electrographic seizures. Okay, so that is one example that will illustrate the point that just because you have a routine EEG showing that it's normal, try to record longer. If you can't get it in 1 hour, then you go to a ambulatory EEG. The basis of doing ambulatory EEG or long-term EEG recording is that there was a study done by Dr. Amanoff and Gooden back in 1981. If you do one EEG, the yield is about 30–35%. You do a second one, the yield increases incrementally. 2, 3, and 4. Then the curve flattens out. So you've got a yield curve that starts to flatten out. You can't do 3, 4 EEGs on every patient. So the concept of long-term EEG was born around 1981. And it has since evolved hugely to include the possibility of recording up to 1 year if you do responsive neurostimulation, which is a totally different area, not required in clinical practice, but it's academically possible to record seizures for up to a year. We typically record in 2 to 3 days and we get the answer.
Thank
I
you.
hope that answers.
Yes, thank you. But most often we do intraictal EEGs. There are short and there are typical cases that we can pick up, but the resistant cases obviously need either a video EEG or a long-term ambulatory EEG. Then there is somebody asking, what do we have EEG courses that we can attend over here? So
Yes.
I can answer that. There are several courses that are going on from IAP, from the pediatric neurology community. Also, the British pediatric epilepsy course is run at various places. And of course, Dr. Suri and his team had come from America and did a very nice 2 or 3 day EEG course out here in Delhi about 6 months back. Right? Anything you want to add to that?
Yes, sure. So the primary goal of what I'm doing is my affiliation is with the Dr. Colonel M.L. Suri Foundation, which is to improve EEG and epilepsy training. And we teach EEG and all the various neurophysiology modalities, evoke potential sleep, intraoperative monitoring. We will be back again to do that course. The next one is February 14th, 15th, 16th at Ganganam, and then again 2 more days at another hospital, 3 more days at another hospital, and we'll keep you posted. So you can watch our website, or you can directly reach out to me or to the Defense Colony staff, and they will provide you that. Secondly, we have an ongoing course that I can give you access to for free. There's no charge, which is ideally for your technologists, but also for those who want to do the clinical neurophysiology board. It's run by Maggie at Maggie Marsh Nation is in Tennessee. It is a 12-module course, and you have to pass each module. It requires you about 1 month to do 1 module, and then you graduate to the next and so on. If you finish all 12 modules, the technologist has a 95% chance of passing the ABRET boards. And you can do the boards right in Delhi without getting a passport or visa. And I can help you with that. So please contact me later for that.
So with this, I think I should hand it back to Dr. Praveen Kumar. Thank you very much. There are a lot of accolades and thank yous in the chat box. Thank you very much.
Yeah. Thanks very much, sir. I think it was very, very well illustrated and very well pointed out the EEGs and especially the fallacies and the small points which we need to take into account whenever we ask for the EEGs and when we look for the EEGs in the recording per se on the part. And it is very nice to have illustration about the 3 hertz, less than 3 hertz, and more than 3 hertz. That's a very, simpler way to understand and to prognosticate also on those parts. And especially the way the EEG reports should be written and interpreted also in that context. I think we have taken the questions, and I think most of times it also the onus comes to us also as an kind of like clinician, that when we ask for an EEG, we give a good account of the history also to the person who is reporting the EEGs. The EEGs, I mean the type of seizures, and if available the neuroimaging findings, because that always helps us when we review the EEGs on the part. So as a clinician, we must make efforts to write a good history, the seizure semiology, the background, and available neuroimaging findings when we ask for an EEG with our neurologist colleague on that part. I've got one question, sir. Number of times we do come across that a child with an structured epilepsy, he continues to have abnormal EEG, although he doesn't have seizures for almost around 2 years, 3 years. What normally you do in those kinds of cases, where even after 2 years or 3 years, maybe 3 years of anti-seizure medications, the seizures are controlled, but the EEG continues to be remarkably abnormal because of the scar in the brain on the part. Maybe a word from you about this, maybe from Nandan sir also in that part.
Yes, so that's a great question, Praveen. It's one of the more difficult problems. If you have a structural abnormality on the MRI, the EEG is focal, is abnormal, I would be reluctant to completely take the patient off all anticonvulsants. But I do everything possible to reduce the anticonvulsants to the lowest effective dose. So that's step one. The second scenario is where you have a condition like benign Rolandic epilepsy. The EEG remains abnormal. The patient's on anticonvulsants. We generally do not use anticonvulsants in that scenario. We try to stop them or avoid anticonvulsants at all when dealing with benign Rolandic epilepsy. And that paper was done at Gangaram Hospital. And it's on our website. If anyone's interested, have a look at it. It was published in Neurology in 1989 or 1990. And the basic premise is that you have a benign condition. The EEG is very angry looking, and there is a guaranteed, by definition, remission in that condition. So what would be the advantage to giving anticonvulsants? We can discuss this later and offline, but that paper brings back a lot of memories, because those patients are actually Dr. Chok, Arya, Dr. Khanna, and Dr. Prutis from those times, which were reported. That study could not be done in the US, by the way.
Okay, that's great, sir. Great, sir. So I think we don't have any other questions. We can wrap up the this great scientific session on the part. Any final word from Dr. Nandan sir from your side?
I
Thank
think
you.
we've had a very good session, and thank you for organizing this, Dr. Anupam and the ICH group. Yeah, thank you very much.
Thank you very much, Dr. Nandan, Dr. Praveen, and a big thanks to Dr. Madhav Suri. Thank you, everybody. And